big venue, standing, but there was a spotlight sort of just like that right above, and I realised it was a bit. The spotlight was sort of on me and a couple of other people in the audience. I don't know why. It was a fixed light. So the band, I don't think the audience could see this, but the band, all the band could obviously was us. So people I was with were kind of making a joke of it and putting sunglasses on and stuff, and I just had to get out. It's a bit unnerving when you're watching something and you realise
they're watching you all the time.
I did my junior year abroad at University of Sussex, so I was down
oh, cool,
in Brighton
great.
frequently.
Yeah, it's not far away. You know, there's a football club now, Brighton, the football club. The ground's right by the university campus now. When were you there?
86, 87.
Oh, okay, yeah. What were you studying?
Biology.
Ah.
Oh, yes, they can.
Yeah, no, that's right. I think
He's a famous evolutionary biologist. He was fantastic.
Oh, really?
And he had this wild gray hair, and he would walk back and forth in front of the board, and he'd think of something, and he'd draw it. It was almost like he was just musing. And then he would touch his face and touch his suit.
still flexible and jumping.
Yes, that's part of my DNA, you know.
Oh.
Oh, wait. I think Sally taught me this. I think you said put your bottom at the back of the chair and lean forward. Didn't you teach me that ages ago? I think it's for women. You guys don't have
It's like, doesn't apply.
I'm pretty sure it was you, Sally.
I sent him a message yesterday, and he said, "Are you here?" No, I'm
Yeah, I'm sure.
here today.
It doesn't work very well.
Thanks.
So we're going to have to, this is an odd way to be sitting, because we're going to have to come behind you.
So the left WHO website.
Well, I don't know, for some reason, Sally wanted us this way. I'm sure she had a reason.
So you could.
Questions will come up here.
So that's why you're here. Okay.
You
And then I
They
two.
can-
couldn't move this.
You two could go that way. Well, do you want to come off the? No.
Wait.
Okay. Yeah.
Well, this is what's happening. We have to think of things
Yeah, it's a good
like
argument.
slips, skirts, nylons, tripping.
They missed it.
Many years ago. I didn't
Not medical.
So you're a doctor?
That's
Yeah.
I'm not a doctor.
Not, you're a mister.
Growing up, so
Very much.
our youngest turned 18 in September.
Yeah. Sorry, I know some organisations. It's
And our eldest, Ben,
it's quite normal. I am a lawyer, yeah, but I don't. So I practice a little bit, yeah. But there's no prefix that
We don't
goes
really
with
do
that.
that, yeah.
Yeah. Are you you're a doctor?
roams through.
So do you use those in WHO? I guess there's a lot of doctors at WHO. Yeah.
So, this is kind of fun field work, I think. And now he's a father.
No.
That's the mention the names. I think that's what I'm going to do.
I'm not old enough to be a grandfather.
Advertise. I think you should.
Yeah. So he's doctor, mister.
Good, especially, Joe's
And my wishes to Joe also.
will do. No, well, and you're carrying the heavy load now, Nurse Global?
No, not yet.
No?
I'm carrying lots of responsibilities in this global, but so far.
So is it time?
Left a bit late, I was.
You could kind of call people to
How are you? Good to see you.
Good morning. Yes. Good morning, everyone. Could we please settle down so that we can start the session? Good morning once again, and thank you for coming in so bright and early to join us in this session. My name is Evelyn Ansah from the University of Health and Allied Sciences, and I'm going to be moderating this session. So just a few points before we start. We all know that the RTSS vaccine, when it was first reviewed, was found to be moderately efficacious, high impact, with a few potential concerns. And the vaccine, therefore, had to undergo almost 2 years of a pilot implementation just to address these concerns as part of the decision-making process. And this, as we know, did not come without considerable time and other resource cost implications. I'm reminded of a paper, a 2016 paper in The Lancet by O'Brien and others. And I'll quote from this paper. And what it says in this paper is that BedNet implementation provides an important historical lesson. Remember, this is 2016. The initial efficacy trials in the 1980s showed about 50% protection, but major delays in their rollout ensued while donors questioned their value. LLINs are now recognized as one of the most cost-effective interventions available in health, and many lives were lost during the interval from efficacy trials to the large-scale use of LLIs, unquote. So did we learn the lessons from the BedNet implementation? I leave that question to you and to the presenters. So subsequent to WHO's recommendation of the RTSS vaccine for widespread use, one more vaccine, R21, has recently been recommended, taking a shorter route than the RTSS had to take. Other novel vaccines and health technologies are currently in the pipeline. And the questions we wanted to ask that remain relevant for discussion in this symposium and thereafter are these. Will the donor community be willing, or should they fund similar efforts for other novel vaccines or biologicals in future? The second question is, will institutions that develop these products be willing to commit the resources and bear the associated risks that may be required to support such efforts? And the third is, how do we ask the right questions regarding upcoming new interventions and do this as quickly as possible so that an effective intervention gets to the beneficiaries in good time? The session will provide diverse perspectives on the pilot program, its benefits, limitations, and costs towards informing future decisions for other vaccines that are currently in development. And to contribute to these discussions are the following speakers who will briefly introduce themselves before they speak. We have, starting from here, Mr. Milois Savic, Mr. Jonathan Hutchins of Med Access, and he will tell you something interesting about their role. And then we have Dr. Miloy Savic of GSK. We have Dr. Rose Jalongo of the National Vaccines and Immunization Program in Kenya. She will join us virtually. She should be on the screen soon. And then we have Dr. Mary Hamel of the WHO. So I welcome you to an interesting symposium. Thank you very much. I'll hand over to Mary.
Good morning. And thank you, Evelyn. I'm Dr. Mary Hamel. I am the malaria vaccine team lead at WHO, and I lead the MVIP for WHO. It's a pleasure to be here to give you some background about the pilot implementations and what we've learned so far. So the first question, I suppose, is why was there a pilot for the RTSS vaccine? And you have to go back to when the results of the phase 3 trial were presented. That trial was conducted between 2000 and 2014 at 11 centers in 7 African countries. Over 15,000 children were enrolled in 2 age groups, and this was across a wide range of vaccine malaria transmission intensities, and included low, moderate, high, and highly seasonal transmission. And the results from that trial showed that the vaccine had modest efficacy with high impact. So there was about a 50% reduction in clinical and severe malaria during the first 12 months of follow-up, but waning efficacy over time, so that a 4th dose was needed to maintain protection. And there were, nonetheless, thousands of episodes of clinical malaria prevented per 1,000 children vaccinated over the 4-year follow-up of that trial. Now, despite this high impact, there were key questions at the end of the trial that needed to be answered. First, it was a vaccine with a novel schedule, starting with 5 months of age, but importantly, that 4th dose was required for optimal benefit, and it was given at around 2 years of age, after the time when most children had completed their vaccine schedule. Without that 4th dose, although there was efficacy against clinical malaria, there was not efficacy. Efficacy was lost against severe malaria, and there was concern that there might be rebound, and resources spent towards introducing this vaccine may not be well spent. And then importantly, there were 3 safety signals for which causality were not established, but they were sufficiently serious that they needed to be carefully monitored. These included, in the 5 to 17-month category only, an imbalance in meningitis cases at 10 to 1. In a post hoc analysis, a higher number of cerebral malaria cases in children receiving the vaccine than those who did not at 2 to 1. And in the combined age categories, also in a post hoc analysis, a higher number of female deaths in children who received the RTSS vaccine than those who were in the comparator arm. Now, by 2021, these safety signals were not seen as signals in the pilot introductions, but back in 2015, we were concerned about these. So, on the advice of the Strategic Advisory Group for Experts on Immunizations and the Malaria Policy Advisory Group to WHO, WHO recommended a precautionary approach and recommended pilot implementations of RTSS with phased subnational introductions through the routine immunization programs to inform policy on public health use of the vaccine. And the pilots were designed to address 3 outstanding questions: the feasibility of reaching children with 4 doses, the safety in the context of routine use with emphasis on meningitis and cerebral malaria, and impact on mortality, including gender-specific mortality, and on severe malaria. And the goal was to inform the WHO recommendation on the use of RTSS vaccine in young children. So setting up a pilot is a formidable task. There are scientific, operational, and financial components, and these take time and a lot of effort. So first, 10 countries came forward and said that they would like to participate in the pilot introductions. Ghana, Kenya, and Malawi were selected based on pre-specified criteria. The countries then had to review the vaccine by the regulatory authorities, and in all 3 countries, they approved the vaccine for use in the pilot areas. The vaccine was donated by GSK, but we don't do a pilot for pilot's sake, and so we need to ensure a long-term access commitment from GSK so that there would be vaccine at the end of the pilots. There was funding that had to be raised. Pilots are expensive, so in excess of $70 million needed for the 6.5-year program, with unprecedented funding coming through from Gavi, Global Fund, and UNITAID, for which we're very appreciative. 2 independent oversight bodies needed to be established, a DSMB and a program advisory group that have reviewed data and advised on the pilots throughout. And then we needed evaluation partners in 3 countries, the 3 countries with strong expertise in sentinel hospital and community-level surveillance. And in each country, there was a consortium of partners that were contracted, and PATH is the key partner for the qualitative study. So to assure a rigorous evaluation, the areas were randomized to receive vaccine either at the beginning in 2019 or later as part of phased introductions, with the comparator areas serving as comparators. There were 4 components. There was a malaria vaccine pilot evaluation with sentinel hospital surveillance and community-based mortality surveillance, as well as a series of household surveys. There was also a qualitative assessment, an economic analysis, and the GSK Phase 4 study. The countries themselves had to do a lot of work, as they always do with new vaccine introduction. They integrated the vaccine into their routine schedules in the pilot areas. They did their training and supervision, as they usually do with regular service delivery of vaccines. The reporting was through the routine systems, including the DHIS2. There was community engagement, as always, but also telling why the pilot was happening. Logistics had to be put in place. And then there was important integrated messaging that emphasized that although the vaccine would reduce malaria cases, children would still be getting malaria, and so it was important that use of bed nets continues, other preventive measures, and care is sought promptly for fever. So we needed to understand how the data were going to be used from the beginning, and WHO convened a group of experts who helped develop the framework for a WHO recommendation in 2019. And this framework ensured that a recommendation would be made as soon as a risk-benefit of the vaccine was established with the necessary level of confidence such that the vaccine would not be unnecessarily withheld from countries in need if it was found to be beneficial. And after 2 years of pilot implementation, it was found that the concerns regarding the safety signals had been satisfactorily resolved, and severe malaria or mortality data were consistent with a beneficial impact. And that was when, in 2021, WHO recommended the vaccine for use. The pilots then continued and will continue through the end of this year to understand better the value of the 4th dose and impact on mortality. And if any adjustment needs to be made to the recommendations, it can happen at that time. So again, data from the MVIP in 2021 showed no evidence that the safety signals seen in the Phase 3 trial were causally related to the RTSS vaccine, and then the recommendation was made. So just a couple weeks ago at ASTMH, Professor Dr. KP Asante from Katampo Health and Research Center presented the findings from 46 months of surveillance from the vaccine implementation, and I'll give a high-level overview here. Since 2019, nearly 2 million children have been vaccinated with RTSS, and over 6 million doses have been administered. The vaccine is confirmed to be safe, with no evidence of the safety signals in the Phase 3 trial, and no new safety signals after all these doses. There is high impact during the 46 months of vaccine introduction, with really a remarkable 13% reduction in all-cause mortality. And I just want to pause here for a minute because it is remarkable that a malaria-specific intervention is leading to this level of impact against all-cause mortality, and really goes to show how much malaria contributes to child deaths in these areas. There also is a 22% reduction in hospitalized severe malaria, and this impact was measured in children who are age eligible to receive the vaccine. Remember, it's in the real-world setting, so as the vaccine was rolled out, when overall in these countries there was from 64 to 74% coverage with 3 doses and less than 50% uptake in dose 4, and yet this level of impact could be measured. Also, through the pilots, it was shown that the vaccine is feasible to introduce with high uptake, with no reduction in ITN use, care-seeking behavior, or the uptake of other vaccines. There's very high demand by the community and acceptability by health workers, and there was an important equity component with the vaccine being delivered equitably by gender or SES, but also reaching children who are not being accessed or aren't accessing other form of malaria prevention tools. So it's taken over 30 years to bring this vaccine through development to the point of rollout. The vaccine was taken through the phase 1, 2, and 3 clinical trials. The phase 3 clinical trial was over 5 years. That allowed for evidence on efficacy, but also time to look for rebound and duration of protection. In 2015, the EMA published their positive scientific opinion on the vaccine, saying that the benefits outweighed any risks. And then in 2016, WHO recommended the pilot introductions for the reasons I've mentioned. It took several years to set up the pilots so that the first introductions in the 3 countries didn't occur till 2019. And then I mentioned with the framework for policy recommendation, 2 years later, WHO was able to recommend the pilot for use. The Gavi board very quickly responded to this and provided their decision to fund the RTSS vaccine rollout. And then the applications started to come in, but these processes take time. So now 18 countries have been approved for Gavi support, and the first vaccines will be rolled out in early 2024. But I just want to take a moment to recognize that the time period from the EMA positive scientific opinion to first vaccine rollout is 9 years. Far longer, I think, than we had hoped for or anticipated, but these pilots take time. So WHO took a step during this period to look at how can we use the lesson learned from the pilot, how can we convene experts to see how we can make this process more efficient for future vaccines. So I'm going to just spend a moment to talk about the MVIP and RTSS as a pathfinder for second and next generation malaria vaccines. So the large scale and the length of the MVIP really provided the opportunity for scientists and WHO and partners to consider and answer important questions regarding the development of future malaria vaccines. For example, we reconsidered trial endpoints. Was it necessary to show impact on severe malaria when that's a relatively rare finding that can be influenced by interventions put in place during a trial? And it was decided that, in fact, clinical malaria is a valid primary endpoint for these pre-erythrocytic vaccines. We also revisited the data on rebound with a full review of the evidence and saw that rebound happens less frequently than expected, but when it does happen, it has never been to the extent where the benefits where the rebound outweigh the benefits seen earlier with the intervention. And so the decision was that a vaccine or an intervention can be recommended before waiting for rebound, and the rebound could be measured during longer-term follow-up after a recommendation, and any mitigation measures put in after. The robust data from the MVIP on safety, feasibility, and impact supported the WHO recommendation for broad use, but also built trust in the vaccine and really fostered this high demand. It established that a moderately effective vaccine will be acceptable and is highly impactful. And it showed that because high coverage can be reached through established system, vaccines can reach children not protected by other preventive measures, hopefully, potentially reaching those more marginalized populations and higher risk children as well. And it also resulted in the establishment of the Gavi malaria vaccine program to support scale up, with 18 countries already approved and what Gavi has described as unprecedented demand. So the result of these efforts is an accelerated timeline for the second vaccine. And from 2024, there will be 2 WHO recommended vaccines and sufficient supply for all children who could benefit from malaria vaccination. So the application of these lessons learned during the pilot period really accelerated the development and review of the R21 Matrix M vaccine, which now has been WHO approved since October of this year, without cutting any corners, with still a very strong review on safety, efficacy, and public health use, but really leveraging lessons learned during the MVIP and with the RTSS. And so now the introduction of the R21 vaccine is expected to be within 1 year after the phase 3 trial data primary endpoints were met. So I want to just take a step back for a moment to reiterate the importance of continuing with our current malaria control interventions. What we would not want to see is a substitution of one intervention for another. We know that it's with a strategic mix of interventions that we can get highest impact against malaria. And Professor Paul Milligan used the resources on the right to develop this figure that I'm sharing. So if you have an area of highly seasonal transmission where there's no malaria control and you add Bennett's, you can expect a reduction in malaria of approximately 45%, which is what was seen in the efficacy trials. If you then include SMC into that mix, you can reduce malaria by 78%. If you have ITNs and SMC and a malaria vaccine, you can reduce malaria by 92%. So it's by this, including this mix of interventions that we're going to get where we want to be with malaria control. So the key takeaways from my presentation is that the pilot implementations have shown RTSS vaccine introduction resulted in high impact, and the vaccine has a strong safety profile. The pilots provided important data and lessons, but establishing and conducting the pilots contributed to a delay in the widespread use of the vaccine. Without the pilot introductions, however, I really feel that questions would have lingered on vaccine safety, feasibility of reaching children with this 4-dose schedule, and the impact that could be achieved. And these questions might or would have delayed development of subsequent vaccines with similar formulations, including the now approved R21 vaccine. WHO's guidance on clinical trial endpoints and measurements of rebound, the established high demand, and the Gavi finance mechanisms being in place all have accelerated the implementation of the second malaria vaccine, R21, resulting in 2 vaccines and anticipated sufficient supply in 2024 to reach children who would benefit. And finally, just reminding again that we must not replace one malaria prevention intervention for another. Thank you. Oh, sorry. Thank you. And I do want to acknowledge the many groups that have contributed to the MVIP, the 3 ministries of health, of course, the evaluation partners, PATH, GSK, London School, UNICEF, the funders, the external monitor, the reference lab, and the researchers, both for the qualitative and quantitative research. So thank you very much.
I would like to say that we will have all the presentations one after the other, and then we'll have ample time for discussions.
We're bringing in Rose Jalango from the Kenya Ministry of Health. She was not able to join us in person. Good morning, Rose. Please go ahead.
So I can have the slides? Okay, so I can have the slide projected.
They should be projected. Can you please project the slides?
I can't see
there
them.
We go. We have them.
Yeah, okay.
Wonderful.
Yeah, all right. All right. Okay, thank you. Yeah, so I'm going to give the perspective of Kenya's experience in implementing malaria vaccine as a pilot country. Next slide. So we did introduce malaria vaccine in Kenya, in the western part of the country, where we do have a high burden of malaria. So initially, during the pilot implementation, we did have 8 counties that were selected to introduce the vaccine. And within the 8 counties, we had a select sub-counties that introduced the vaccine initially. So they're shaded in purple. And then the sub-counties shaded in pink were acting as a comparator sub-counties. And then we have those sub-counties shaded in black that did not participate in the pilot implementation because they had not reached the threshold to introduce the vaccine. So the initial implementing sub-counties were 26, and within those 26 sub-counties, we had all the health facilities introduce the vaccine, so either faith-based, private, or public. Next slide. We formally launched the vaccine in September 2019, and we had several attendees from globally and locally. Next slide. So in terms of how we introduced, we had it's a 4-dose schedule. So our schedule was first dose given at 6, 7, 9, and 24. And these were integrated with other childhood interventions. It was part of the schedule that we do have, but it's only that it was being given at a sub-national level. Next slide. In terms of how the uptake was, we do have the first phase of vaccinating sub-counties. And we compared the uptake of malaria vaccine that was introduced vis-a-vis other antigens like the pentavalent that have been in the program for over 4 decades. So what we did find out is that the uptake of the pentavalent vaccine given at 14 weeks and the RTSS given at 6 months were actually comparable. We also compared the uptake of RTSS given at 9 months and the measles rubella 1 given at 9 months, and the uptake was quite comparable. It's only that the measles rubella 1 uptake was a little bit higher. When we go to the second-year platform of life, we compared the second dose of measles rubella given at 18 months vis-a-vis the 4th dose of malaria vaccine given at 24 months. And again, the uptake compare in that we do have a challenge with the uptake, especially in the second-year platform of life. So malaria vaccine literally mirrored the other antigens in the immunization program. Next slide. So in terms of what we did after we received the WHO recommendation that the vaccines were now available to all the other African countries. We did review internally within our decision-making mechanism, and NITAG recommended that we do scale up the malaria vaccine to the comparator sub-counties. And again, we did have those preparatory activities in those sub-counties that later led to the introduction of vaccines to those additional counties. So we had the opportunity again to do an application to Gavi to access vaccine doses beyond the pilot implementation phase. Next slide. So in terms of some of the benefits that we did have within the healthcare system by introducing the malaria vaccine, one of the key elements that we did have is the collaboration between immunization program and the malaria control program. Again, routinely, these programs don't work together, but it was an opportunity to work together with the National Malaria Control Program. So other health system strength and benefits included expansion of cold chain equipment, strengthening of vaccine safety surveillance, and also some aspects of integration with other childhood programs. Next slide. So we did discuss malaria vaccine within our decision-making mechanism as actually projected on this slide. Next slide. So in terms of how we coordinated with the malaria program, malaria program came in handy, especially when it came to making data-driven decisions. So they gave us data on where we need to introduce the malaria vaccine. So in addition to making it a data-driven process, we had areas of efficiencies in terms of working with the malaria program. So for instance, we had joint activities, especially in advocacy. So during the World Malaria Days, we could advocate for both the malaria vaccine and also other malaria interventions. And then secondly, at the service delivery points, we did training materials that targeted the healthcare worker on both vaccination and also malaria program activities. Other engagements, like for example, community engagement, advocacy, training, were actually done in close hand in hand with the malaria program. Next slide. So these are examples of the key messaging that we passed across, again, emphasizing that malaria vaccine is a complementary tool into the already existing malaria prevention tools that have already been rolled out by the malaria control program. Next slide. So in terms of the lessons learned from this pilot is that number one, for the other countries that are going to be introducing the malaria vaccine is that working hand in hand with the malaria control program, because the vaccine is a complementary tool to the additional tools that are already within the country. And then secondly, the importance of evidence, especially when it comes to decision making. And then the other lesson is that, again, the malaria vaccine works in terms of reducing the burden of malaria in the various aspects, reducing the burden of malaria. So we've also seen some of the health system strengthening benefits that we've had, especially when introducing the malaria vaccine. Next slide. So in terms of the cost, of course, the pilot came at an additional cost. So there were those costs that were covered by Gavi, Global Fund, UNITAID, additional partners. And again, they covered those aspects of the preparatory before the vaccine was introduced. So community engagement, capacity building, expansion of cold chain equipment, because again, it's not covered within the new vaccine introduction platform. Next slide. I think in conclusion, one, we've seen that Kenya was among the countries that participated in the clinical trials, and we were selected alongside Ghana and Malawi to pilot the malaria vaccine within the country, and we used the existing infrastructure to pilot the malaria vaccine, and we've seen that the uptake was actually comparable to those vaccines that have been introduced before within the country. And even as I go to my last point is that whereas so far we do have at least 1.6 million children who've received at least one dose of the malaria vaccine across the 3 countries. We see that we missed an opportunity to reach out to many more other children, hundreds of thousands, during the pilot implementation. But again, it was necessary to answer the questions, to find answers to some of the questions that were raised before the pilot implementation. Thank you, and over.
Meloya?
Hi, good morning. Hope you can hear me. Good morning, all. My name is Miloje Savić. I'm coming from GSK, where I lead the cluster for the global health at the Value Evidence and Outcomes, and we are actually overlooking scientific and operational aspects of the GSK's phase 4, which is nested in the pilot implementation. And then I will tell you something about the challenges and opportunities that we learned during this long process. So the global health and GSK, our purpose is to unite science, technology, and talent to get ahead of the disease together. So it's a 3-pronged approach through global health R&D, where we develop new vaccines and medicines, access, pursuing equitable access for GSK's portfolio and pipelines, and capability building, to reach the patients who need them the most. And the global health team is around 200 people in GSK. So the RTSS malaria vaccine presented really unique high-risk challenges. In contrast to most vaccines that are used globally, malaria vaccine was really developed specifically for sub-Saharan Africa, which comes really with significant challenges which are related to pharmacovigilance, regulatory pathways, policy recommendations, development for funding, pricing commitments, procurement financing, and manufacturing investments. In my talk, I'll mostly focus on first 3, like pharmacovigilance, regulatory, and policy recommendations. To give you a feel of the evolution, how the phase 4 evolved over all these years. So starting around the time when we were expecting the EMA positive scientific opinion, the initial design of the phase 4 studies was based on, of the phase 4 was based on 4 studies looking at the baseline and the safety study, kind of looking at the before and after vaccine introduction, looking at the impact and vaccine effectiveness. And then the expected vaccine implementation was somewhere around 2017. However, things kind of changed, and the vaccine was not really introduced in 2017, but was planned to be in 2018. And then the plans also changed, extending the studies, thinking about to evaluate the 4th dose, what would be potential rebound. Therefore, the sample size of the children that would need to be involved in the studies sort of changed almost on an annual basis. Recalculating all the time your study designs and sample sizes. Further changes in 2017, still expecting, the vaccine implementation in 2018, again, changing some of the objectives, in terms of looking at the long-term effects, safety monitoring, and the effectiveness of the RTSS malaria. I'm really skipping a lot of details because of the time, but really giving you an overview. And then I'm expecting also the pilot implementation program to start early on in 2018. However, the implementation really started in 2019. And this is, let's say, the current situation, how the studies looks like. There are 4 complementary studies, the 02, which looks at the baseline incidence before of malaria, meningitis, death, adverse events before the vaccine was introduced. In 03, we'll look at the vaccine introduction, monitoring safety and effectiveness, and in parallel, there are 2 studies looking at the parasite prevalence and use of malaria control interventions, with also evaluating the parasite genetic diversity. And of course, the MVP that's going on in parallel in the surrounding areas, in the clusters, and will finish this year. So looking at the consequences of this quite complex vaccine profile, complex policy, regulatory, financing pathways that were not known or not were always clear at the time, the nesting of these phase 4 into the pilot implementation resulted in a 9 years gap. If you look from the time of the EMA positive scientific opinion in 2015 until the first introduction of the malaria vaccine in the countries outside of the MVIP program. We went through slight delays, when the vaccine will be introduced. Then in 21 came the WHO recommendation. The Gavi approved the malaria vaccine funding, the pre-qualification in 22, and then it started expansion into unexposed areas in 3 countries in the MVIP, and then now under the joint review of the dossier for RTSS vaccine, the first introductions will probably start in early 2024, after, the time scale of 9 years. So the consequences, conducting these interventions, the pilots and any phase 4 studies programs in low and lower middle income countries that come with limited capacity for comprehensive pharmacovigilance have their own limitations that may prevent really robust post-authorization vaccine safety and effectiveness monitoring. The selection of participating clusters was really dependent on the ministries of health, who were according to the WHO guidance. Therefore, the company was not really involved in the process. However, the studies were conducted in the setting of the routine medical practice and local laboratory testings. However, since the pharmacovigilance systems were not really up to not really robust for what they were tasked with, GSK's introduced pharmacovigilance enhancing program that was comprised of study-specific trainings, telemedicine support, second-line laboratory testing, and consultation with external experts who were charged to do the final cases classifications. So the pilot implementation, the impact that it had on GSK's phase 4 planning and studies, not to repeat the timelines, but really to focus on this part here, that the plans were changed several times, at least 7 major protocol amendments, and which resulted on changing the study designs or their objectives, length of follow-up, sample size and enrollment strategies, change of site and countries, loss of data in countries that started early on the surveillance, like Senegal, Burkina Faso, and Tanzania, and then initiation of new countries and data collection like Malawi. Then major investment in capacity building to establish well-functioning pharmacovigilance system able to collect adverse events and assess RTSS effectiveness and impact. Even further on, the pilot implementation had impact on RTSS manufacturing, because within this time period of relative uncertainty whether the vaccine will be recommended or not, GSK stopped and then restarted manufacturing activities to produce 10 million donation doses for the MVIP. Then the manufacturing activities to enable the MVIP program were conducted before WHO recommendation for a larger rollout was made, and before Gavi decided to fund the malaria vaccine immunization program. So to overcome these challenges and avoid putting the manufacturing facility on hold again, GSK developed an innovative financing solution with Gavi and MedAccess to de-risk the manufacturing activities and to create a stockpile of vaccines before awaiting policy decisions and financing. And then eventually only after WHO recommended vaccine for the broad use in October 2021, GSK could submit the files for the WHO pre-qualification and national market authorizations. And with that, I'll thank you all for your attention.
Morning, everyone. So that last bit from Malloy was an introduction or mention of MedAccess's role. I'm a brief introduction to myself. I'm Jonathan Hutchins. I'm General Counsel and COO of MedAccess. I'm actually I'm a lawyer by background, and I've worked in development finance for 30 years. So our perspective on this is quite unique, both in the context of the session, but I suppose also MedAccess itself is quite a unique organisation. And I'll talk a little bit about that now and our perspective. But before I do, I just want to say how proud we were to have been invited to be involved in this. We played a relatively small role, given you've seen the timeline and the huge amount of good work that was done, including the work done by my colleagues on the panel and the organisations they represent, and also the organisations that Mary mentioned. So we came in with a particular perspective. This session is about different perspectives, the costs and benefits of the pilot programme. So we're a social finance company. That means that we provide financial products, or generally in our case, we're providing finance not for profit, but for social benefit, and in this case, clearly public health benefit. That's what we do. We usually provide it by guarantees. We've reached more than 530 million people in over 95 countries since we were formed in 2017. And we've done that through 9 deals. This is our second actually deal in the malaria space. We also supported the intercepted G2 nets produced by BASF with the volume guarantee. We are backed by $200 million of capital from British International Investment. That is the DFI, the Development Finance Institution of the UK government. So we're part of UK aid policy, but in a very specific sense. And this is a good case study of showing how that works. But generally, as mentioned here, we use innovative finance products to secure agreements like the one here, although this was a very bespoke product, and that's intended ultimately to accelerate access to health products in low and middle income countries. So that's the context. We were invited, our involvement in the story starts really in 2019, where we were invited to get involved to try and help resolve some of the issues which you've heard already around the protracted, I suppose, manufacturing commitment that GSK was making as a result of the sort of the extended timeline and the MVIT program. And a huge amount of donor money had already been put in through more traditional grant methods. And there was an attempt to try and find an innovative finance solution to keep the good work, keep the momentum, preserve the impact. So when we came in, we put it through our normal lens of how we make investment decisions, but it was, as mentioned, quite an unusual exercise for us and quite a peculiar challenge. But we were able to leverage much of the hard work that had already been done and much of the data, particularly on impact. And that's relevant because we look at 2 things when we're making a decision. We have to basically establish a development impact case. We have a particular development impact framework, which requires satisfaction of criteria under these 3 headings on the left here: lives changed, money saved, market shaped. But we also have to establish that the risk to us is tolerable. We'll take more risk than our partners. That's why we're involved. But it still has to be, tolerable, and it has to be proportionate. And we have to work out that we can manage that risk, because the model we use, we're not for profit, but we're financially sustainable. So we have a mandate not to make grants like Gabby, who we were supporting here. We're supposed to preserve the capital, but to make pledges to healthcare partners and actors in a situation such as this, so that they can continue to make impact. We'll support them with a financial product, but we'll take on risks that they won't be able to take on. But the ideal scenario, obviously, is we don't pay out on the guarantee, though obviously we're willing to do that. And that means that we also have to charge a fee. It's a proportionate fee. It's not intended to make a profit, so it's risk reflective, and that's one of the other costs of the, again, with reference back to the subject matter here, one of the costs of the MVIT program. So on lives changed, Mary's given some really compelling data. When we were looking at this in early 2020, we referred to some of the information that was already available from the pilot, the estimate of 39% reduction in malaria cases, on lives changed, on money saved. We estimated that this the benefit of keeping manufacturing going and not having an interruption in the production of the antigen antigen would be a 12% cost saving, and that would be we estimated a $56 million saving both to Gavi and governments in the long run. And market shape, this is a more qualitative assessment of the long-term impact of an intervention like this. You've heard the perspective of GSK. What would be, I mean, our assessment in a situation like this is what would be the negative consequence if GSK decided that there wasn't sufficient support in the donor community or amongst its partners to keep this going in this situation? What would be the consequence for generation of demand for the malaria vaccine long term and the impact that would have on people's lives? And also, subsequent malaria vaccines would be helped by keeping this thing going and helping create the market for malaria vaccines, both through Gavi and at the national government level. On the risk assessment I mentioned, we needed to satisfy that as well. We had to put ourselves really, so this is an unusual case. Usually we do demand modeling through volume guarantees, which is a different kind of product. But what we were really taking here was policy and regulatory risk. So we needed to take from Gavi itself and also from GSK the risk that there would not be a positive WHO recommendation at the end of the MVIP, and that or that Gavi didn't open a funding window. So to do that, we could come to our own view about what should happen, but we had to put ourselves in the shoes of the decision makers, and that was quite an unusual exercise, but an important one, and involved many of the same demand modeling exercises that we usually go through. So that culminated, we decided to do the deal. I made that decision in early 2021. And we were therefore, by putting these agreements in place, which are quite dry set of legal back-to-back agreements, but the consequence of this was to keep antigen production going. GSK maintained their plant because the risk was taken off them via this arrangement with Gavi and us, and the stockpile continued, and we maintained continuity so that when the decisions finally did come through happily, all of the benefit of the work that had been done to date since 2015 and even before that had been preserved, and we're in a much better position today as a result of it. But our role in it was actually quite brief. I mean, it could have gone on longer. The decisions could have been later. At one point, it looked like it might have been, but WHO came to a decision, as you've heard, a positive policy decision late in 2021, shortly followed by a Gavi funding window being opened. And that meant that we were off risk by that point. But what we'd done here was we basically, Gavi had provided a working capital facility to GSK in the meantime, and we had de-risked Gavi by providing a guarantee of what we called an antigen production support agreement. And that under that arrangement, the net consequence was that GSK continued to produce 15 million antigen doses over 24 months. And we did charge a fee for that. It was a risk-reflective fee I referred to earlier. So just taking a step back now and thinking about, I suppose, the perspective of an innovative finance investor and also a supplier and the different actors. This is an interesting case study, and this slide is relevant to RTSS, but it's not exclusively related to it. It's a general observation about the impact of market uncertainty and what can happen in these situations and how we can how they can be resolved. So basically, I think what we ended up in is as a consequence of the uncertainty around the regulatory decision or policy decision, we have a situation where the conditions were not in place for continued production of the antigen, and that gap, if you like, a different kind of gap from the one maybe summarized in the title, but nonetheless a gap. That's what we do. We tend to think of ourselves as bridging gaps where there's an obstruction in the way the market is working. that we can help by de-risking key players at key moments in that process. So what we can do as an impact investor is as you've seen, is resolve or mitigate and take away some of these risks in those critical periods mentioned here, so that in this case antigen production can continue, but also resolve some of the risks which Malaho mentioned from a GSK perspective are peculiar to sub-Saharan Africa, lower middle income countries. And what we're trying to do is to continue to build confidence amongst decision makers at manufacturers that the continuing R&D commitment and continuing production commitment here is worth it. It's in everybody's interest, an alignment of interest, and we can take risks away at a crucial point. Similarly, with Gavi, there's a limit to how much Gavi could put in as pure grant or commit to purchase without being de-risked from some of those consequences, and we were able to do that here. And then once our job is done, the actors can continue with a, as indicated here, the gap is closed, the momentum is preserved, and the impact is preserved. And that is, that's the end of my presentation. Thank you.
Thank you very much. And I suppose for some of us, this what went on behind the scenes to have the RTSS vaccine still produced and get to the beneficiaries was on our blind side. I suspect some of us are hearing about these arrangements behind the scenes for the very first time. Thank you very much to all the presenters. We are now going into a short time of discussions, and I would want to start with clarifying questions, burning questions, and please make sure your questions are brief so that others will have a chance. But whilst you are preparing, I'm going to ask Rose a question. And Rose, my question to you is, would Kenya participate in a future similar pilot for another important vaccine? Would you participate in such a pilot?
Thank you for the question, and it's definitely a yes, because we've seen the importance of pilots in terms of generating evidence for scale-up of new vaccines and also interventions. So it's a definite yes.
Okay, thank you very much. So I'll go to the audience and then, okay, so yes.
Okay, thank you for the presenter. Thank you to the presenters. I have one question. The first one is regarding Kenya. You started the pilot phase just before the starting of COVID-19. Do you have some evidence if COVID-19 had a negative impact on the rollout of this phase? And the second question is, what have been the criteria for selecting the countries to do the pilot out of those who participated in the initial phase? Thank you.
I think the first one would go to Rose and the second one to you, Mary. But please, if you could ask one question, one each, and then we will come back again. Please ask one question. So we'll take the third question. The third question, yes, please. Somebody has the microphone. Okay. So let's follow the microphone.
Okay. I'm a professor of global health, and as you know, I've raised some critique about the design and the data analysis of the pilot implementation study, both in BMJ and Lancet. The microphone is working? Yes. I think some of the aspects were illustrated today in the presentation from Kenya, namely the aspect in relation to confounding, because the vaccine was rolled out in conjunction with growth monitoring, vitamin A supplementation, and deworming that was piggybacked on the vaccine rollout. So in reality, the study is comparing malaria vaccine plus these interventions versus no interventions. That can be difficult to change once the implementation has been done, but there were also aspects in relation to the data analysis, the change of mortality to be a safety or an impact outcome rather than a safety outcome, meaning that the analysis was only done from the third dose, and also the post hoc change in the data analysis plan including an age control group. So I think for these reasons, for us to rest reassured, it's extremely important that independent researchers be given full access to the data sets for making the analysis that we find appropriate, which would also include more scrutiny into the aspects of sex differences and according to the booster dose, etc. So my question is for you, would you grant independent researchers access to the data for this kind of reassuring data analysis? Thank you.
Okay, so I think we will take some answers first, and please make your questions brief. And then also indicate who you are putting the question to, if you can. So perhaps we'll have Rose respond to her question, and then Mary.
All right, thank you for the question on the impact of COVID-19 on the uptake of malaria vaccine. Yes, I do agree that we rolled out malaria vaccine in September 2019, and then months later we did have the COVID-19 pandemic. But what we learned during that time is that, one, there was no impact of COVID-19 pandemic on the uptake of malaria vaccine, again demonstrating the resilience of the immunization program and also the demand from the community for the vaccine. Secondly, apart from the COVID-19, at the tail end of 2020-2021, we did have a healthcare worker strike in Kenya, and we did have a dip when it came to the uptake of all antigens, including the malaria vaccine. But several weeks after the healthcare worker strike was resolved, again, the performance bounced back to its original performance grade. So it basically shows the resilience of the immunization systems, and again, in addition, the demand and the awareness of the caregivers on the importance of malaria vaccine. Thank you.
Thank you.
Can you hear? No.
Yes, we
can. You can hear me? Okay. All right. Thank you for the questions. On the first one, the criteria that were used included, there were about 6, but included having a high malaria burden, high child mortality, good malaria control measures in place, a functioning EPI program, having the ability to collect the data in a rigorous manner, so local research organizations, and having participated in the phase 3 trial was an added advantage. And there were a couple more, but I don't have them all on the top of my head. Regarding the point from Christine, first, the data shows that there actually was not increase in deworm, unfortunately, because we wanted to see increase in full utilization of these additional visits, and we're now trying very hard with partners, we just brought it up at the RITAG, to see how to fully use those visits. But unfortunately, there was no increase in vitamin A uptake, in deworming, in the uptake of other vaccines as measured in the household surveys. That being said, your question is about access to the data set, and we do make the data available by WHO standards when the paper is published, not the full data set, but the data to be able to reproduce the analysis. And that 24-month paper is under review right now, so hopefully that will be soon.
Thank you.
Yes, thank you. I have a question for Mary. In the study reported by KP, it showed that the 4th dose coverage was less than 50%. When we all know that both in the phase 3 and the pilot, that 4 doses is very important to have a good impact of the vaccine. Do you think we should develop a innovative delivery approach to increase that? And do you think also that in our clinical trial methodology, we should include endpoints regarding 1, 2, or 3 doses impact on the vaccine? Thanks.
Okay, the next question.
All right, good morning. Thank you for your presentation. My name is Nobu from Nigeria. I have quite a lot of questions, but I'll restrict it to one.
One.
All right. Have there been an assessment on the impact of acquired immunity at the age of 5 for the child? Because that is a very important factor when it comes to malaria in highly endemic area like Nigeria. Was there any study or assessments done on if the child is able to acquire immunity at the age of 5? Thank you.
Yeah, a question to Milok on GSK. Really a sort of counterfactual. If when EMA gave their positive scientific opinion in 2015, as GSK might reasonably expected, that would have led to a WHO recommendation for use. It didn't. But if it had, would the cost of the GSK vaccine has been as high as it appears to be now, about sort of €9 a dose? And would the limitations on supply, which for RTSS are really quite severe now, still have been the case? I know it's a difficult question to answer in the absence, but I think an important question, going back to Rose's original question about sort of delays in rolling out interventions.
I think we'll take the last one from you, and then we'll... Yes, please.
Thank you. My question is to the professor who spoke first. You mentioned the delays in terms of bringing the vaccine to market from the instance when the first positive opinion was issued by the EMA. And you mentioned several factors that influenced that delay. And one of them was the limited pharmacovigilance in low and middle income countries. So could you just comment on the extent to which you think the limitation in the availability of ability to perform comprehensive pharmacovigilance in those countries contributed to that delay? Would it have been faster if it had been in place in terms of allowing you to choose a different endpoint which excludes the severe malaria and going only with the clinical malaria? Thank you.
Okay, I think we will allow them to answer, and then we'll...
All right, should I start
Yes,
with the question
please.
about the fourth dose? Thank you for this question. I think it's really remarkable to think about this, or worthwhile to think about this a little more. That impact that I mentioned, the 13% reduction in all-cause mortality, was in the setting with very few children having received the fourth dose, which implies that if any rebound occurred, it was not sufficient to overcome that high impact. So important point. There is a nested case control study as part of the MVIP that's going to look at the added advantage of the fourth dose. In mathematical modeling using the phase 3 trial, it was estimated that there was only a 10% additional benefit from the fourth dose. So we do believe that the fourth dose results in higher efficacy. We saw that, but we don't know how essential it is at this point. Right now, the recommendation for WHO is to have 4 doses. R21 is also a 4-dose vaccine. I do think it would have been advantageous to have had one arm of the R21 trial having 3 doses, but it wasn't done that way, and we'll see with future vaccines. I think your point is good. We do want fewer vaccine doses for many reasons. And then you asked about innovative ways to reach children with a fourth dose. So I think that would be really important to look into this. One very simple way that Ghana has addressed this is they moved the fourth dose to be at the time of the measles 2 dose at 18 months of age. They did that when they expanded into the comparator area. and immediately the coverage of the fourth dose went up very high. So the recommendation for WHO has been that countries can have flexibility of when to give the fourth dose, but they should consider aligning with other vaccines in the second year of life. But I think there are other opportunities. It could be that parents are told at the very beginning that when they come in for their 4-dose schedule, of course, children are given a bed net usually early on in maybe their first vaccine visit, but maybe that fourth dose they're told when you come in you'll get a package of health interventions which includes a bed net or some other innovative means to increase the fourth dose. So I'm sure you have ideas, and I think that these would be very much worth exploring. Then there was a question on acquired immunity by age 5. In the phase 3 trial, I can't find where that person is. There, okay, in the phase 3 trial, it did look like after the third dose with waning immunity and after the fourth dose with waning immunity, the children ended up having similar immunity to children who had not received the vaccine by the time they reached either 3 years of age or 4 years of age, depending on if they got the fourth dose or not. So we do understand that acquired immunity is still occurring. It is a partially effective vaccine, right? Children still get malaria when they get the vaccine, but fewer cases and less likely to get severe malaria. But this could be studied more in more depth. Should I hand
I think you hand over to, yes.
Yes.
Yeah.
So thanks for the question about the production. So usually what would happen, yes, I think we were expecting after 2015 that malaria vaccine will be implemented. And therefore the capacity to produce antigen would usually be scaled up. Ideally, with this scaling up of the production, your price usually goes down as the economy of scale. However, doing the pilot implementation delayed all these activities or decisions whether we should scale up the production or not. Therefore, I think this uncertainty in the policy and the pathway, you know, what's going to happen with the vaccine, whether the vaccine will ever be recommended by WHO, resulted in GSK being in a limbo, what to do. Therefore, the production facility was never scaled up, and it is not possible to have, you know, the factory or the facility and then repurpose it for something else, because it's just impossible, because you need to have all the licenses go through all the regulatory procedures and so on. Therefore, you can only decide to shut it down. And now, to have a downward pressure on the price for the vaccine, we are doing the tech transfer with the Bharat Institute. Therefore, the bulk of the antigen will be produced in India, and the GSK will continue producing the adjuvant. I hope that answers the question.
Thank you very much. Following on this, Jonathan, I would like to ask you a question. This uncertainty he talked about, you talked about an innovative way of dealing with this. Is there another way, or would you do the same if there were another situation like this?
In this particular situation, I think it was a very bespoke agreement. So I think we were in effect providing something that we were asked to do, which is quite unusual, and some of the guarantees we do are like that. You could, in established markets where there's less regulatory risk, if you're through the regulatory approval and there are a different set of challenges, for instance, GSK just wasn't sure about the market, or the producers not sure about demand because they don't have visibility. We provide something called a volume guarantee in that situation, and that's a simpler product where we take demand risk, not regulatory risk. But I think, I think in answer to what's encouraging to us about this is the ability to be flexible, to work with partners to design something that is very specific. So it's difficult to maybe to conceive of a situation where exactly the same thing would happen again. But what's encouraging about it is that we were able to work with partners to find a mutually acceptable solution, and the alignment for access, even with people, obviously you're dealing with a commercial partner like GSK, and more aligned partners in terms of global access, like Gavi. You still manage to find, I think, in these deals quite a lot of goodwill and flexibility to find alignment.
Okay, so it means it's context specific. It depends on the situation. Thank you very much. Any other questions? Yes.
Could Milo and I respond to the one question that we didn't quite
okay,
get to?
Then.
About the pharmacovigilance, I believe if there is a stronger surveillance system in the country, that maybe the pilot wouldn't be needed. And we know that, from the vaccines, for example, which are used in a global market, when you have a countries, the mixture of countries with a stronger and less strong or less developed pharmacovigilance system, at least you can exchange the safety information between the countries, by monitoring in one and then informing the other one. In this case was a really unique situation that malaria vaccine wouldn't be used in Europe, where we could rely on these pharmacovigilance systems. Only in African countries where we know that these systems do not function perfectly, that they really need still further development, further investment in people actually who are dealing with the pharmacovigilance, and their trainings needs to be constant. Now, after the pilot, where is that sustainability coming in, keeping the momentum? That's what I would like to see, essentially.
Mary? Okay, okay. Any other questions? Yes, please.
Actually, it would just be kind of take a little bit of privilege here. I apologize, and I want to thank everyone for coming today, but also, what advice would you give to others who might be considering similar kinds of pilots, and are there alternatives? I would just love to hear any thoughts that any of the speakers would have on that point. Thank you.
Yes, I think you all have to answer.
So I get asked this quite frequently, believe it or not. I think people see that a lot came out of the pilots, that it was highly successful. It really built this trust. And so for several different vaccine antigens, I've been asked about, and even non-vaccine interventions. And I advise them to think very carefully about doing this and really consider what the alternatives are and what the question is. I think you've heard you've heard about the sort of impact this had on GSK's ability to come forward with a vaccine, sufficient vaccine at a low enough price at a time when there was a real momentum at GSK to move this vaccine forward that was not realized in the same way because of the pilots disrupting that. And then, although we're extremely grateful for MedAccess, we wish we didn't need them. So I do ask when I'm asked this, if it's to show impact, then do it another way. Roll it out and show impact as you go. Do a case control study. Do a nested study, but don't slow down rollout of a vaccine that's potentially life-saving. If it's about safety, then it gets trickier because, as Milo just said, I think the EMA, when they gave their positive scientific opinion for the vaccine, they assumed that it would be rolled out and the pharmacovigilance would take care of looking for these signals, but with the phase 4 study in place. But you have to look at what can be captured in these pharmacovigilance systems, and does something more robust have to be set up? And I think that depends on the specific safety question and signal. And I'm sorry, but just one more point is the context today is different from what it was in 2015. So first of all, in 2015, people who weren't living in malarious areas thought that malaria was really coming down and that the tools we had were going to get us there. And so this was not seen as such a crucial intervention at that time. People living in malarious areas, as I had been just prior to then, were already seeing malaria going up and seeing that there was a real problem on the horizon. But also it was pre-COVID. And I think a lot has changed with COVID vaccine. We moved forward with introducing COVID vaccine in an age group, a number of age groups, on schedules that we hadn't tried before. And we didn't step back and say, well, can we reach these people with this schedule? There were safety signals with COVID vaccine that we went forward with. Of course, we had strong pharmacovigilance systems to monitor for those. But I think that things are a little different now with respect to moving forward with vaccines that are life-saving in areas with high burden.
I think we have no further questions. We'll be bringing this session to a close. But I see that we've learned a lot of lessons. I read a quote from the Lancet paper earlier on about bed nets. And from what we've done with R21, we appear to have become very nimble and with the COVID vaccines in how to introduce, making sure that a good technology, a good vaccine gets to the beneficiaries in time, whilst ensuring that we don't put people at risk. Like Mary said, there are alternatives to this, and we have learned from R21, from RTSS and all that went on. We will still be continuing this conversation, and we will talk among ourselves about this. I want to first thank the presenters, all of them, for making time to present to us and to share with us. Rose, who is virtual, and the three presenters here, we want to thank you very much. And I want to thank you, audience, for coming so bright and early and staying with us right to the end. Thank you all very much.
It's a very good answer. Couldn't have improved on it.